Good evening, everybody, and welcome to the next edition of the IDEC Cafe. Today, we've got a very exciting evening ahead. And, along with me on the panel is Dr. Neeta Deshpande, Dr. Archana, as well as Shilpa. And we are very excited to listen to our guest speaker today, Dr. Manoj Chawla, who's going to walk us through, how to look at CGMs. I'm sure each one of us who practice diabetes has now felt an urgent need to know about reading CGMs because that's the way to go for the future. And, while we know that glucose testing is important, HbA1c is a good marker for assessing glucose control. But now more and more, we are getting into the era where we talk of new parameters like time in range and time above target, time below target. And if you have to look at glycemic variabilities and so many other markers, then continuous glucose monitor is the way to go. I'm going to ask our fellow panelists right now till Manoj joins up that what do they think for the future? That do you think that CGM is going to replace all other markers for glucose control, or is it going to be an add-on? So Archana, let me ask your opinion first.
So I think, sir, it's definitely a more patient-friendly, a direct eye-opener for the patient. So one is a doctor helping you out retrospectively. With the HbA1c, we know what happened in the last 3 months. But with real-time sensors, it is amazing how a patient themselves can actually titrate their doses, see where the glycemic variability is happening, where their meals, the way they're being absorbed. So I think that's a way to go. If the cost is affordable and real time can be used, most patients would be very excited to empower themselves in their own control.
So, Neeta, I mean, you do a lot of, CGM. Then we've now got Manoj online. So we'll just wait for him to clue in. But I'm just going to get a sense from you that you have a huge practice in Belgaum, and I'm sure you use CGMs. Yes. Would you like to give the audience a sense of feeling that which are the patients that you use in your clinical practice, CGMs?
Yeah, so as of now, we use it need-based. May not be for everyone because of the cost and the technology not being understood by everyone. But basically, we use it in type 1 diabetics as much as possible, people on multiple shots of insulin, and people who have a discrepancy between their HbA1c and their blood sugar readings, or somebody who's not able to prick multiple times. So there are numerous indications. But going forward, what I see is now a triangle. We are going to have in the future, I feel, at least in India, 3 pillars. You have your HbA1c, then you have your self-monitoring of blood glucose on glucose monitors, and then you have your CGM. So they're all going to be complementary to each other is what I see in the future.
Manoj, are you ready? Let us know. We are waiting for you. Manoj, you're muted.
Hi, Sanjay. Hi. Good evening, everyone. Sanjay, Archana, Neeta.
Good evening and welcome. Welcome to IDEC.
Welcome to this edition of IDEC Cafe. And I want to welcome Manoj. He's a dear friend. And I think nobody better than him to give this talk today on continuous glucose monitoring. He's got immense amount of work. And you can read from his introductory slide the kind of work and this man has done across the country in the field of diabetes. But his area of interest lies in technology used in diabetes. And when we were looking at, what is the topic that would excite most people, we thought that, CGMs is the way to go. And we requested Manoj, and readily enough, he agreed to give time in his busy practice to say, let me take this. And thank you, Manoj, for being with us today evening. So just a short introduction of Dr. Manoj Chawla. He's the Director and Consult Diabetologist at the Lina Diabetes Care and Women Diabetes Research Center. He's a consulting diabetologist at the Hinduja Hospital, Rahija Hospital, and the BSCS Municipal General Hospital in Andheri. He's the part of the Executive Committee, All India Executive Committee of the RSSDI. He's been the Scientific Chairman of Diabetes India, Organizing Secretary of Diabetes India in 2022, and is a visiting faculty at D.Y. Patil Hospital in Navi Mumbai. He's been awarded the RSSDA Fellowship and the Fellowship of the Royal College of Physicians of Edinburgh. And he's been part of the principal investigator of many global clinical trials. So with this short introduction, I don't want to waste the time, and I want to give Manoj the opportunity to speak more. So over to you, Manoj, and you can share your slides and start with the presentation. We're keen to hear you.
Hi, evening, everyone. If I would have known that Sanjay is going to say these things about me, I would have readily, joined in every time, even without being invited. So it's an absolute pleasure to hear Sanjay say such good things about me, at least. So thank you,
This is a
Sanjay.
one-time offer.
So thank you, all of you, for having me at this IDEC cafe. And as I had requested, thanks for making sure that I have my cup of Irish coffee ready this evening, which will make sure that I remain engaged, and I hopefully engage everybody who's joined in for the next hour or so. I must congratulate you guys for this initiative. I'm surprised to see on my phone, and I was just chatting, I have requests from some known KOLs from across the country who are actually asking me that will we get a recording of today's conversation, and I've just said we'll check with the team IDEC on the same. And of course, I'll forward to you whoever has asked for that request, and you can do that. So
we will be having the recording.
Yes.
No problem.
It will be available on the IDEC website.
Okay, great. So let me start by sharing my presentation. I would honestly love to do this more in person, wherever, when you have people joining in, it makes it more interactive. I love to see the expression of people sitting in and ask questions and ask queries, and what drives most of us, including all of you organizers, is the engagement and interaction with the audience, which gets us more excited to talk on any of the topics that we are more passionate about. And surely for me, it is monitoring and continuous glucose monitoring.
Yeah, let me just interrupt you there for just 1 second. And you are going to get a chance to do this in person at the IDEC conference, which is at the end of June. And I urge everyone who has tuned in here to actually register for the conference. I'm taking this opportunity because Manoj is going to be there in person as well.
Yes.
So you may proceed, Manoj.
Thank you. So what Neeta is asking me to do is just take 40% of the presentation today and leave it suddenly in between, so that for further come to Pune and get the complete thing done. So great idea, Neeta. I'll probably do just that. I will ask the questions at times and not give the answers in today's thing, or not show the solutions and invite them over. Anyway, let's get started. And let me find this presentation and get the sharing thing done. Here, okay. So an interesting topic, in the sense that, yes, I do speak on CGM regularly. So I was happy when I saw that, yes, learning CGM step by step. And I'm also glad that we have enough time in today's coffee conversation to give me the leisure of time to take everybody here through the entire journey of CGM. And what I'm doing is starting right from the basic. And some of you would be extremely well aware of what the whole thing is. But I believe that I'm reaching out to an audience through IDEC Cafe of those who know this pretty well. Some of them may know this much better than I am and have greater experience. But we also have a lot of physicians and experts treating diabetes from across the country and outside who are joining in, who are interested in learning more about the nuances of CGM and what are the different CGM. So allow me the liberty, all of you who are joining in, to take you through the basics and then move into a little finer aspects over the next hour. Okay, so when we move right to the beginning, what really is continuous glucose monitoring? Well, it's important for us to remember that it's a method to track the interstitial fluid glucose levels through the day and night. What we actually measure through all CGM devices is not blood or plasma glucose, but it is interstitial fluid glucose. Continuous glucose monitoring devices, as the word speaks for itself, allows continuous tracking of this interstitial fluid glucose, which of course draws parallels with blood glucose levels, though there may be a certain lag. And this lag period differs from technology or device or company which makes the CGM device. As a representative way, easy to understand that whether you have a CGM which requires a sensor and a transmitter, or directly a sensor attached to the body, you will typically have something which is attached to the top of the skin with a sensor which is dipping into the interstitial fluid, which is allowing this to measure the interstitial fluid glucose and transmit that to the monitor which is capturing data. You may have a different monitor, or in many of the devices across the world today, this data may be transferred to an app on a smartphone which can collect the data. What also all of you should realize that it is not actually the glucose which is measured, it is the metabolism of glucose or the conversion of each glucose particle into specific electrons, which gets measured by most of the CGM devices. Those number of electrons are directly proportional to each glucose molecule, and that's how you get the number. The earlier CGM devices, for that specific reason, required calibration by entering a glucose value which is checked on a glucose meter. Even today, some of the technologies used across the world for CGM require calibration. And that calibration is because the device doesn't actually measure glucose, but measures those electrons in numbers. You need to calibrate by entering a glucose values, and that's how it picks up and start giving us the respective consecutive values ahead in a continuous tracking manner. So we start from the beginning after having understood that CGM is actually measurement of interstitial fluid glucose and not blood glucose. But why do a CGM? Well, as this illustration would show, that even if you have a patient who may do multiple finger pricks, which actually is very difficult, it's easy for us to recommend that do a 7-point SMBG, but doesn't happen very often. People will struggle, will come up with various reasons. You'll have very few people who are so diligent and who would do that, but the large majority of our patients would not do the frequent SMBG that we would advise them to. And even if they did, as we can see here, somebody who's doing 4 times SMBG may pretty much be in the target zone or the good range, which we see, but we may be missing all the zeniths and nadirs, the peaks and valleys, the ups and downs, which is what the glucose moves through on a single day and then on a day-to-day basis. So which is where continuous glucose monitoring, which is going to capture the glycemic trend over a period of certain days, 7 days in some technology, 10 days in other CGM technology, 14 days in what we use predominantly here now, the Libre series of CGMs. And I must at this point say as a disclaimer that I am not contracted by any of the CGM companies today to speak for their product, but I've been asked by IDEC to talk about CGM as a concept and how we can really do it and learn better and use this technology better. So, and then of course, as I was mentioning, 14 days, which is what we use predominantly here because of the non-calibration required in the Abbott CGMs and the cost effectiveness as compared to the other CGMs, and of course the length of the time that you can use it for, which is 14 days, which is more than the other CGM devices. Also, it's good to understand right from the beginning that CGM would essentially be 2 types. You have professional CGM, which actually involves patients who wear a CGM device, or you put a CGM device onto them, could be the tummy, could be the arm, and this is typically done in a doctor's clinic. The monitor to see these sugars or the software to download the sugar trend or graph over the preceding days that your patient has worn the CGM typically is in the doctor's clinic and not with the patient. The professional CGM is also hence called blinded CGM. That means while the patient is wearing that, he or she does not get to see the sugar values actually. However, of course, there are now means of hacking this and using different apps to try and see those values, but we keep the hacks out of today's conversation at least. So truly professional CGMs are blinded CGMs, also called as retrospective CGM. And then you have personal CGM devices, which patients use. And today, that's the actual strength of CGM. We are encouraging more and more of our patients, especially those who use insulin, be it type 1 or type 2, to use CGM if they can afford it, because that allows them to see their sugar on a real-time, continuous basis. It allows them to make decisions to their diet, their lifestyle changes, their exercise, and of course, their medication, especially insulin adjustment, which is what ideally would have required them to check SMBG, but which gets difficult, and hence CGM allows them to change their dosage as they see on a day-to-day basis. What's also important for us, all of us at this stage, to remember that if you're treating patients with type 1 diabetes, it was rather naive of all of us to assume that our patients have similar requirement largely on a day-to-day basis, and it's only minor adjustments that they require. Most of us who started using even insulin pumps in the last decade and a half or two would typically set the basal dose for the insulin pump and teach and train the patients to slightly monitor and adjust their bolus dosages, learn carbohydrate counting, look at their insulin sensitivity factor, insulin to carb ratio, and adjust their bolus dosages. However, today, we understand that that is not enough. The requirement for basal insulin, especially in patients with type 1 diabetes, changes almost on a day-to-day basis. And which is where we are realizing the strength of automated insulin delivery devices, the hybrid closed-loop systems, which integrate the CGM and algorithms with automatic insulin delivery, because that's what allows, based on the continuous sugar tracking, to change the basal insulin supply in patients with type 1 diabetes on a day-to-day basis. Coming back to our conversation here, two types of CGM: professional, which is for looking at the trends and used by doctors' clinics; personal CGM, more for patient self-use, and that's where they have to be not only encouraged but equipped to use the personal CGM or real-time CGM to its optimum capacity. So let's look at these two. We have the Freestyle Libre Pro, where the doctor is explaining that, and then attaching it to the patient at the clinic. They have to come down after a duration and download the data and understand their trends, and then discuss the therapeutic and lifestyle changes with their doctor. Or you have the Freestyle Libre, which is for the self-use, and patient learns to use it themselves, monitor the sugars continuously, make changes continuously, and probably also share their downloaded data with their physician and see them in person, or in many parts of the world today, discuss it through a telemedicine portal or a telecall, and with after data sharing. So you're looking at Freestyle Libre Pro. As I said, we largely tend to use the Abbott series, which is the Libre series, and Libre Pro was the first Abbott professional CGM, which was launched anywhere worldwide in India several years back. Most of us got fascinated by this Libre Pro CGM because it came at a cost lesser than the previous Medtronic CGM. It was easy to use and importantly, did not require calibration by doing finger prick testing and entering the data. So Freestyle Libre Pro, which is still the predominant used CGM in India, is small and discreet, is water resistant. It's a fully disposable sensor. You don't require a special, a different transmitter, which is the problem still with many other CGMs, that you require a transmitter to be attached to the sensor, which means that once you buy a transmitter, which could cost anywhere between 40,000 to 80,000 rupees, You can use it only for one patient at that point in time. Whereas in the Libre Pro, this is the reader which is there at the doctor's clinic, and the same reader, with that same reader, you can simultaneously get patients started on a single sensor, and you can download the data. So there is no restriction, or your one reader does not get utilized or stuck. You need only one reader at the clinic, and you can do multiple simultaneous CGMs on different patients. Thin filament, which goes below the skin, for 14 days of data, blinded from the patient, no additional components. It's just that single sensor on the arm. They just have to take care that they don't uproot it, especially while changing clothes or moving around. They don't bang their arms directly onto the sides of the wall, and the direct impact sometimes can let the sensor come off. The cons of Libre Pro, well, it doesn't let the patient know anything. It doesn't give them any high or low alerts. It's completely blinded. The transmitter adhesive sometimes may not be good enough, though we don't see this problem much. It does have inaccuracy in the low glycemic range. So hypoglycemia may be falsely aggravated, and that's the accusation. And very often that may be right, that in the low range, you may not find great accuracy. And sometimes we even ask patients to cross-check it by doing the good old SMBG at that point. Sensor placement, people try it at different places, but it's not approved for anywhere else besides the arm. You can see some MARD. Of course, the physiological differences between interstitial fluid and capillary blood may result in inappropriate glucose readings in some patients. It may be affected by dehydration. And just like every technology, including HbA1c, you do have interfering substances for a lot of CGMs, including vitamin C. Also, you may have interferences with high dose of aspirin and so on. And sometimes the adhesive reactions. We move from Libre Pro to look at Freestyle Libre, which is the personal use real-time CGM, right? And as I said, I'm largely referring to these because in India, at least today, where we have limited options of CGMs available, you have the Medtronic ones and you have the Abbott ones. Dexcom, some people use it, but not directly sold. It has to be gotten from outside. So the large usage is Libre. Freestyle Libre, you're looking at the pros. No calibration, again, needed. Water resistant, single button press insertion, low profile transmitter, lowest cost amongst the real-time CGMs, has the shortest warm-up. That means after you attach this, for the first 1 hour, you don't get the data. It's the warm-up period. And after 1 hour, the patient can actually start scanning and start seeing. And this is why this particular CGM is also called as intermittent scan CGM system. That means the generation which is available in India, you still are using the generation 1 sensor for Freestyle Libre. It does require you to scan it to get the data. The advanced sensors in the Freestyle Libre Abbott system, the sensors 2 and especially the sensor 3, does not require the individual to scan. Once they put the sensor, the data is being continuously transmitted to the app on the phone. You don't need a separate reader like this black one with all the alarms of lows and highs and the same life of 14 days and no need for finger prick calibration. The limitations, of course, of this one Freestyle Libre available in India is that unlike the generation 3, it is still not giving us any real-time high or low alerts. The patient scans, they can see the reading and they can see the sugar is low, but it doesn't ring an alarm for somebody to be aware. It doesn't allow you to share the data. Calibration is not available. And sometimes one believes that if actually you are able to calibrate, you may be able to be actually increasing the accuracy of that particular device. Reader requires up to 3-hour charge every week. And the software, which is actually not officially available yet in India, which is extremely disappointing that the product is available, but the software is not, doesn't allow the patient to download the data and share it with the family or the caregiver. Now, when I've been explaining the both, I think I'm clearly putting out the difference between these two. But if you really want to understand further the difference, the goal of Libre, which is the Freestyle real-time continuous glucose, the goal is to help self-management of diabetes. Libre has features which helps in diabetes self-management. There is an option when you are doing the scanning that at that point in time, you write down that whether this was pre-meal, post-meal, I took my insulin dose, I went for exercise. So it does allow you to add a lot of that. And you can scan the Libre and see the data at any given moment. The more scan you do, the more information that the individual gets. So that's the strength of Freestyle Libre. As compared to that, the Libre Pro, the goal of use of Libre Pro is not to provide direct assistance to the patient themselves at all. The goal is to aid the professional, that means the doctor, and the consultation between the doctor and the patient to understand their glycemic trends and then work towards improvement in improving the time in range ahead or seeing a better HbA1c in future. If using Libre Pro, the patient only has the sensor and no reader. Let's be very clear. Patient has to visit the clinician to scan and see the data. Which means that today, as a doctor, if you have to decide which CGM should I use, you have a patient where you're seeing inability to reach HbA1c or fluctuations or disparity between their SMBG and HbA1c. This patient could be most likely type 2 on multiple OHAs with or without insulin, and you want to know what's missing. You offer them the CGM as Libre Pro. However, if you have a patient that is type 1, who ideally needs to see their sugars on a daily continuous basis, or you have a patient with type 2 who is on insulin, maybe just basal plus or maybe complete basal bolus or premixes, who ideally has been recommended to check because does experience some fluctuations and variability. For such an individual, if they can afford, the advice is Freestyle Libre use. So if I can repeat myself, if you're looking at studying a pattern at one time, maybe you're going to do this CGM twice a year or once a year, go for the Libre Pro to see the trend. But if you have a patient who's using insulin and who needs to monitor regularly and make decisions, the Libre Pro unfortunately doesn't help much. For such an individual, they should be using only the real-time CGM. Now, many in India may not be able to afford in a self-pay market the real-time CGM use on a continuous basis. Doesn't matter. Even if somebody uses it once in 6 weeks and the rest of the time they're doing their SMBG, for the time that they are using it and they're continuously seeing their sugars, that continuous reading or glucose trend availability is what is going to prompt the patient to make changes in their lifestyle, in their medication, in their diet, and see the difference there and there itself. So hopefully I'm clear about where to offer whom what kind of CGM. Now let's look at the application of the sensor. Simple when the person is applying self. You get the single simple applicators, which you will apply to your arm. It's usually the back and the underside of either of the arms. There are simple steps which are available. The back of the arm is recommended. Choose a side that is at least 2.5 centimeter away from an insulin injection site. Avoid areas with mole, scars, tattoos. Do not use body lotions or creams where you'll apply. Let that be clean and dry. Body hair, if it's there too much, you can actually ask them to shave because that would interfere with the adhesive there. To prevent discomfort or skin irritation, you could choose a different side other than the one most recently used. So it's not, if you've used one ear, you'll move a little lateral, you'll come to the side, you'll go to the other arm and keep rotating within this side as shown clearly here. Preparing your skin, well, you just need to make sure that it's a clean, dry skin. You could use any of the alcohol swabs, but then wait for the area to dry up. And of course, if somebody is hairy, you could ask them to shave and make sure that there's not hair which is going to interfere with the reading. So this is the way one prepares. When you open up the box of the sensor, you will get the applicator, which is what you will put the applicator into the sensor cup, and a simple twist of the applicator. It dips into the sensor cup and the sensor gets loaded on the inner side of the applicator. Once it's loaded, all you need to do, as shown in the diagram, is the area that you've selected, keep it there and have one press, as this is a collapsible column. It's just one compress, one press, and the sensor gets attached to the skin with the sensor silicone needle going below the skin and staying in the subcutaneous area and beginning ready to measure the interstitial fluid glucose. It's easy to keep your sensor in place with a little extra care. What else do you want your patients to do? Be careful not to catch your sensor on a doorway, car door. So it's usually walking around where you may bang. They have to be careful. What do you mean by hands off? Avoid touching, pushing, or pulling on the sensor, fidgeting with it, scratching around it, it would come off. Extremely important that they are careful while dressing and undressing, because that's the time very often that you tend to pull it off, and it may your top or shirt or whatever may come out with the sensor itself. And after a shower and all, you just have to be careful that you're going to be patting it dry and not rubbing, of course, so that it doesn't come out. But pat it dry, it's waterproof, nothing happens. Now let's move on to understand the personal glucose trends. So with a quick scan of the sensor, your Freestyle Libre shows you different readings, which means that as a physician, start getting used to being familiar with the scanner, which will show you different aspects, which will show you the reading. So when the patient sees the reading 112, what's important with CGM as compared to an SMBG, it's not just showing you a single value. It is also going to show you a direction and a trend. And that arrow is important. So the upward arrow means that the glucose is rising quickly. The partial upward means it is rising, like in the photo here. If it's flat, it means it's static. If it's falling, you will see this arrow. And if it's falling rapidly, then you will see the downward arrow. What you'll also see is the graph, which is for up to last 8 hours from the previous, from the time that you have scanned. And of course, the target range. Now, when somebody starts using their own CGM and they get their personalized reader, it's extremely important that you also tell them that what their range should be. So patients should be taught to make sure that they first get into the setting and setting the range. And what is that range? So the recommended range for the time in range metric is between 70 and 180 for every individual with type 2 and type 1 diabetes. That's the international recommendation from the ATTD group, later on accepted by the ADA and ASD as well. Where do we change? It's the only other place where we have a different time in range is for those who are using it during pregnancy, where we would ideally like to see a 63 to 140. However, a lot of devices will allow only dropping the range till 70, and you'll have to set it between 70 to 140 during cases of pregnancy. What else the reader allows you to see? It's your daily pattern. So with your daily pattern, you can actually develop what you can see is your ambulatory glucose profile. You can see last 7 days. These are all like smartphones. They are touch sensitive. You touch here and you'll go and see last 14 days, last 30 days. So depending on how long the patient's been wearing the different sensors, you'll be able to see the data on the real-time CGM reader. You'll also then be able to see the time in range. So you can see time in range. And what's again important for us physicians helping our patients is when you have their reader in hand, touch it, get into the settings, look at your data, and start seeing the different reports which come in. Now, when you see the time in target, it's not only last 7 days which matter. You can go back and you want to see their time in range metrics for last 14 days, 30 days, up to 90 days. And that's what will give you the larger picture. Time in range is not defined by number of days. You can have patients' time in range metrics that you're seeing for almost up to 90 days or even longer in future. You will see the time below range. So if you want to see the hypoglycemia, when has the patient had how many episodes and what is the time duration? So again, it gives us a beautiful graph divided into quartiles of the day, and you're able to actually identify the highs and lows in different quartiles. And if there is a pattern arising, that is there a concern? Is my patient dropping more between 6 and 12 in the morning, or when is it happening? Is it happening in the night or otherwise? Well, this is something which is showing you the desktop. This is probably the desktop at one of the laptops at our center, where you will have these two softwares to be downloaded. your Freestyle Libre Pro, which is supposed to be only with the physician, as I said earlier, but also the Freestyle Libre is what you can get. As I said, unfortunately not officially available, but available for us to download the data and help the patients. When you connect the patient's reader with your device and you open up the Freestyle Libre software, it will give you the option to create reports and change reader settings. Well, what's important is in terms of reader settings to make sure that the time for the reader use corresponds with the actual date and time, because you don't want the data getting mixed up with the wrong date and time. And of course, the setting, which I said ideally should be 70 to 180. So you will be able to create these different reports with the help of the Freestyle Libre software. And then you're able to save that in your system, that report, which stays with you because you can use it for lectures like these or training or actual research purpose. Now, these are the presentation of reports saved in the PDF format. So you're able to download that data through the software and actually save it with the patient, and patients can themselves also start sharing their data on WhatsApp with their family and partner and have the data for much longer than 90 days. The reader that you use will record the data only for 90 days and not beyond that. And hence, having the software is important where they can keep their data for a longer time. Now, when you see this kind of a freestyle CGM data, it's also important that you notice their time in range data. For example, for such a patient, this percentage in target is poor, only 34, 65% above time, 1% below time. You're looking at the low glucose events also. And which also gets me to the point on CGM, that one of the other advantages of CGM is picking up hypoglycemia in routine practice in patients who may actually have a high HbA1c. Orthodoxly, we would have never thought that somebody who has an A1C of 9.5 or 10 is experiencing hypo. We would have thought all hyper, let's increase the dose. But a lot of these patients have huge glycemic variability, which is why their HbA1c is actually higher, which also means that they are having asymptomatic hypoglycemia intermittently, which is picked up most often only by CGM. So high A1C does not mean no hypoglycemia. So look at that trend, and most importantly, start looking at the number of scans. You have to encourage your patients to scan more often. I would say ideally at least 15 times a day to be able to get enough data in real time for the patient to make changes. Now, when you use real-time CGM, by just scanning 3 or 4 times a day to see what happened earlier, you've lost the opportunity at that time, because your advantage was real-time data, real-time action. Seeing what happened yesterday, I can't change yesterday. I can learn from there and probably not do the same. But as I said, each day your profile is changing. So scan more so that you see your sugars more constantly and make it an actionable change at that time. Now, of course, you will have some patients who will say, this is a bit too much for me. It's too overwhelming. I don't want to keep doing this whole day. Fair. For such an individual, probably CGM is not the best thing to be used. And that's why we say real-time CGM, predominantly for people with type 1 and some type 2 with multiple insulin who would like to be more involved in their own care and improve their profiles, their metabolic control and eventual outcome. Now, these are the different format of reports which you will get from the software, which is showing the AGP, which is showing the daily trends, and also giving you snapshots into what's happening at different time of the day to be able to identify the wrong zones. It will also give you a calendar format of average glucoses and what's happening. It will give you a daily report, so you can actually identify which day the patient has gone up and down with the daily average glucose, and also reports showing the different sugar values, and if the patient has entered their insulin amount or exercise or other information that also you're able to download and see in the daily logs. How to effectively use CGM data. Now, this is important because we keep talking about CGM and AGPs, but let's understand better now how to understand this data. So one is standardize the CGM data, organize it into a report which makes sense, analyze the report, and then use it to optimize the glucose control between with the conversation between the physician and the patient. So how to make best use of the CGM? So for many of us who've been using CGM for a while, you'll remember the time that we struggled with CGM because you would get readings which were all over the place. So how to make sense, how to interpret that data, how to help the patient, because you were not getting clear trends always in the past when you were getting just a single day reading in a different color. So when you start seeing the data, you want to see what is time within range, what's time above range, and what is time below range. How do we monitor our glycemic control? And this is that same example that you can have two patients with different glycemic movements and have the same HbA1c. So HbA1c is a great tool for overall management, overall control. The strongest link with long-term microvascular and probably macrovascular complications. A great research tool, but that's where HbA1c ends, in terms that we're not replacing it, but it's not going to tell us any more information. You want to see the sugars, you want to see the up and down, you want to see the trends. Well, you want to improve probably quality of life. You need more information, and that's what comes from the CGM. So to understand AGP, well, if you have reports like these, which comes from CGM data downloads, and this is what you get. All CGM devices will actually give you reports like this. AGP is actually a copyrighted software ambulatory glucose profile developed by International Diabetes Center, Dr. Robert Maze and colleagues, which have it patented to them, which is a software derivation of this data, which is based on a percentile format, where you are able to give maximum importance to the points which are happening more frequently, and you get the median, and then you get the shaded portions, which are the interquartile and the interdecile range, which I'll come to. So this is the challenges of CGM data. I have many of these old readings with me, where we would convince the patient, pay this much money, do CGM, and when they come back, we get data like this, and then you're scratching your head and wondering, now how do I really help the patient? What do I tell? It's all over the place, and which is where AGP came in as a lifesaver. So it is truly a differentiator. It gives us different reports once you apply. And again, let me remind that though Abbott, through their initial Pro series, got the AGP to us to India, AGP is not owned by Abbott or a single company. It's a software. Anybody can license that. Today, many SMBG devices also have licensed the use of AGP. If you do sufficient SMBG, you can do that. Though clearly, CGM gives us a far better AGP because you have more data points per day. Today, your Medtronic CGMs will also give an AGP, and so will many other CGMs. Only thing is that they have to have the authority and the licensing from the makers of the AGP software. So when you want to understand the AGP curves, the glucose data is actually organized into 5 smooth curves. This is your median. The median means 50 percentile, 50% of your points in that past 7 days or 14 days, whatever you're using were at this particular point, which is what gives you the median. Your interquartile range is the light shaded blue portion, which is between the 25th and the 75th percentile. The light shaded portion is between the 10th and 90th percentile, which is the interdecile range. The 10% of the data above and the 10% of the data below is actually kind of removed, because there were least occurrences, and hence based on the percentile format, you're not giving that occasional occurrence importance, which was the 10th percentile up and down. Now, when you look at this, the graph is a model day plot of all the data. So when you explain to the patients, you tell them that yes, your sugars were movement through the day, but this is like a compressed report representing what is happening to your sugars in a 24-hour format. You would have done it for 14 days, but let's understand, if all of that is compressed into typical 24 hours, what do you see? Like in this individual, you can see the sugars moving from 180 at 12 o'clock in the night, coming down to about 100 here in the morning, jumping up after breakfast, worsening after lunch, probably going above 350, 400, and then dipping by night. So you can see the high variability. You can see the peaks, and you can at the same time also see some of the sugars dropping in the hypoglycemic range. The other reports will also give you the glucose pattern insights in terms of as I said earlier, different time quarters of the day and telling about likelihood of hyper and hypoglycemia. You also get the daily traces with analysis, which is important because you sometimes want to see which were the days that the patient did bad. You also want to identify what he or she ate if they're keeping a log chart to identify what is more individualized in terms of being able to give an individualized diet advice, which helps for patients to see. Those using real-time CGM, well, the patients tend to figure it out for themselves that, yes, today I ate poha, I ate this, I checked my sugars, it went higher than when I had eaten something else. And that's the best way for them to realize what food works for them, what doesn't. Moving to the time in range context. So most of these reports now, in some format or the other, give us the time in range. Like we see here, you're getting the time in range data, time in target, time below target, and time above target for the daily reading. And then importantly, for the entire duration period that CGM device was used. In the Abbott ones, it's going to be 14 days. In Medtronic, very often 7 days. In Dexcom, which we don't have but should get very soon in India, about 10 days data maximum. Well, we further understand to interpret the CGM data, the AGP data rather, what does normal look like? This would be a normal profile for somebody who does not probably have diabetes. And yes, on the AGP for a non-diabetic, you will see some sugars in the 60 to 70 range also for a non-diabetic, non-pre-diabetic individual. It is not hypoglycemia, that's interstitial fluid glucose. And then you will also see trends in terms of what you accept as good control. So this is something that you may accept as good control. You can see the AGP graph, which is thin. It's not wide. Wide would mean more variable on a day-to-day basis. It's flatter, which would mean that it's not varying much within the 24-hour period. So it is pretty much flat movement through the day, right? And you're not seeing the high exposure. That means it's not going much beyond the range of 180. At the same time, you're not seeing the drops below 70, which means no hypoglycemia. So this is a good AGP. This is a great CGM profile to have for a patient who's maintaining an A1C probably closer to 6 or 6.5. Estimated A1C, which has largely been replaced by GMI, glucose management indicator, in the reports in the CGMs in the West, we still have the old format calling it estimated A1C, is just a glucose management indicator. It just tells that what will this kind of a profile lead to. It does not mean the patient's A1C and should largely not be given importance as parallels to HbA1c. So is this good control too when you see this? Well, this patient does have the peaks and the hypos. Now, this patient could very well have just an A1C of 7.1, 7.2, but the lows and highs are actually averaging out the patient sugars, and hence again the need for why we should consider doing CGM in routine practice for most of our patients. So you will always have the risk of hypoglycemia and hyperglycemia, and what you start looking into different AGP graphs is the exposure, as I said, which means what is the range above 180 and where they are peaking. You want to look at the variability. That means how broad is the AGP graph, how much is the variability on a day-to-day basis. And then finally, you want to look at stability. That means, is the sugar going too much up and down within a 24-hour period, or is your graph flatter? Now, this is the principle of actually looking at CGMs and AGP and treating your patients. Let's dwell a little on this. So as we said, this is we're talking about the breadth of your graph, your intertertile range, which is going to talk about the variability. And then you want to see the stability, which means in a 24-hour period, how is the sugar movement? Is it flatter, or is the ball again going up and down? Like in this case, there is some amount of instability, if I can call that. So that's the peak and the exposure which contributes, and this actually increases because if the sugars are going high sometime in the day, there's also a possibility that they're going low and dipping as well. So to simplify the AGP-derived treatment priorities, let's look at this cartoon of the AGP graph. when you have a patient with such an AGP picture, what do you see? You see reasonable variability, because you can see the breadth of the graph, including the interdecile range, to be quite broad at this point in time. Little narrow in the early part of the night, broad again in the early morning. So you see the breadth and realize that this patient is varying too much on a day-to-day. You see the exposure, which tells this patient is at some point of the day even going above the 350 mark. And then you look at the stability. You don't see the graph to be flat. You see at 12 o'clock, the sugars are 280, coming to about 180 in the morning, jumping to 350 in the afternoon, and then again about 250 in the night. So there's a huge movement through the day. So how do you treat such a patient? Your first priority should be reduction in variability. So reduce variability. That means that you're trying to cut down on what is the cause for the day-to-day variations, right? Whether it is the dietary habit, the lifestyle, the medication changes, and you're trying to improve that. So you're able to reduce the variability. You're trying to reduce then the breadth of the AGP graph. The patient should not vary so much on a day-to-day basis. So bring about some time aspects, when the patient is eating food, when they are taking medications, when is the walk time, and so on. The second priority after reducing variability is to improve stability. That means if you're finding peaks and dips within a day, try and change that, whether it is increasing your medication or insulin at some point, reducing at some point, asking for not keeping long gaps between the food, going for the walk exercise at the right time. Your target is to see that the profile is becoming flatter. And that's where it is improving stability, as we are able to do for this person here. Only after you have reduced the variability and improved the stability should you then look at bringing down the sugars, which is called as reducing the exposure. That means get the hyperglycemia down and get this patient's profile from all above the range to within the range. Now that's the beautiful picture that you want to see. If you start trying to treat hyperglycemia, which means reducing exposure right from the beginning without reducing the variability or improving the stability, this patient is bound to experience more and more hypoglycemia, which again would be picked up largely only through CGMs. So interpreting AGP, well, as I've already focused on that, you're looking at all the peaks, the variability, the median curve, and allow me the liberty here to skip some of these slides, including what is called as stability, which means what is the average hourly change in sugar that is acceptable? It's about 12 milligram. Somebody whose sugars are moving by more than 12 milligram per hour, especially in a fasting period, means that there is less stability and the sugars are moving too much up within a day, and that's going to be harmful for the patient. That kind of glycemic variability will also lead to release of oxygen-free radicals and the damage in the long run. In terms of variability, well, what do you see here? The interquartile range is about 51, interdecile range is about 88. Figures which are going to be higher than this is going to be called variable. So for somebody who wants to get these numbers in right, it's 51 for IQR and 88 for IDR. Numbers larger than this would be considered more and more variable. And you also are trying to see the percentage of time when the patient is experiencing hypoglycemia. So let me quickly move to a couple of slides in the last 5 minutes that I have before the IDEC team opens it up for questions. Let's look at some practical cases. 73-year-old female with diabetes from last 35 years, persistent high HbA1c despite treatment changes, complaints of giddiness at nights, but there's been no hypo documented. The patient sugar profiles, you can see here, multiple readings. We're not seeing any low, but the HbA1c is stuck at 7.7, 7.8. We said, let's do a CGM. Now, for such an individual, doing a professional CGM is good enough because you want to catch the trend once and help the patient. So you're doing the professional CGM. What you find here? Well, one, you see that this patient has enough exposure. The variability is not much because you can see that the breadth of the AGPs is not really that high except for some points, but there is no stability. There is huge movement within the day. There is a drop here in the night. You can see the huge post-breakfast spike, post-lunch spike, and some amount of post-dinner spike. Now, such a patient, you will have to have specific medications and time-related therapeutic changes. You're seeing the day-to-day profile also. And what you're able to appreciate in this patient is staying 66% in target, 12% below, and 22% high, which is the essential peaks that you're seeing at breakfast and lunch. So such a patient then can be advised changes in their medication profile, but doing the CGM gives you insight into why this patient is stuck at 7.7, 7.8. And let me remind you, it's not only because of these peaks here, it's also because of the hypoglycemia. Every hypoglycemic episode also is contributing to more variability, the peaks following the hypoglycemia and worsening HbA1c. We look at another case, 51-year-old male with history of diabetes for a year and a half, multiple shots of insulin, usually making changes themselves. This is type 1 individual. And the patient was not too successful with the changes that he was making and based on the SMBG. So the patient was asked to do a Libre Pro purely from the cost point of view. For such an individual, ideally, they should be using real-time CGM. But as I said, not too many of our patients can afford this. And if they can afford it, cannot usually be on a continuous basis. So we said, okay, let's at least see your trend with whatever you're using. Sorry, this is a type 2 patient. I'm saying type 1 again and again. This is a type 2 patient who was not responding much to the orals. Initially was only on a pioglitazone metformin and then on basal bolus insulin. So a type 2, probably a 1.5 somebody may say, who's been on multiple shots of insulin. So we do the patient's CGM, and to try and get to do this better, this is one of the aspects that you can do, which many clinics in India do, calling the patient back in 5 or 7 days, seeing the CGM profile, so you can again appreciate the exposure, the variability in terms of the breath, the lack of stability and the movement through the day. Well, this individual will require counseling in terms of food, the kind of food, and also modifying the insulin dosage and profile that the patient was on. Though basal bolus, you can pretty well make the changes. So we see the profile at the end of 7 days. Patient is still wearing that same Libre Pro CGM. You're advising the changes, and this is the data at the next 7 days. You clearly can see some improvement. If you're not able to appreciate that visually by looking at the graph, you always have the TIR metrics to help you. So within a week, this individual has moved from 47 in target to 66. The time below has increased. And that's the worry that you have when you start just bringing down the sugars. The time above has come down from 52 to 16. But all this has been with the cost of little more hypoglycemia. And that's where we said that you should try and at least improve the stability, which means the straightness rather than just bringing down the sugars, because that would happen at the cost of more hypoglycemia. So after seeing this other 7 days, you are going to reduce the dose at lunch and do the corrections. I would ask the IDEC team to tell me if I have another 5 minutes, because I have a couple of cases, but if they want to open it for question and answers, I'm happy to stop here.
No, you can take another 5 minutes.
Okay, thanks, Nita. Okay, so this is case number 3. It's 13-year-old male. Oh, sorry. A 63-year-old male, type 2 diabetes since 15 years. What this gentleman saw always was constant disparity between HbA1c and SMBG. A senior retired army personnel, if I remember, on basal insulin and multiple OHAs, doing the SMBG reasonably at home. Of course, only fasting and post-lunch, but the A1C would never be under control. He would come to us with the SMBG readings meticulously, but again, every time the A1C would just not be at target. There would be some fluctuations in the SMBG, of course, but nothing consistent. The post-lunch would be 148 and 122 also, and on certain days it would be 220, 260 related to probably the indulgences. But we were stuck after making certain changes in the therapy and to see whether, what we are seeing. Why is then the A1C coming down? Now, again, he was suggested that let's do a professional CGM, because like I said, We wanted to see the trend once, so a professional CGM is good enough. And see what we see in the professional CGM here. What is the AGP graph? This individual, we're not seeing any highs. There are some spikes here touching 180. Of course, there is always a possibility that when you put a CGM, sometimes the patients get extremely conscious and would be on their best behavior for the next 1 to 2 weeks. Though we tell them that, don't do that and don't get conscious like a CCTV camera is watching you, do your right thing. And that's where we are going to be able to help you the most. So you see this trend, but essentially the larger outcome of this CGM was that this patient was experiencing hypoglycemia in the middle of the night, which was being missed. Also, this could belong to a group of individuals who will have a false high HbA1c for one of the multiple reasons that is there in literature. But when you start seeing this kind of a profile, you're not going to be increasing the dose surely for the medications and reducing it and counseling more on diet and exercise. This is an interesting case. Female teacher by profession, SMBG shows reasonable control. A1C persists to be high, like the previous gentleman, and she's doing the readings. Now, a very typical case where fasting's been usually good. Posts are between 150 to 180, but A1C comes exponentially higher. We do what she really does is she was having a small breakfast and she takes her insulin because that's when she's leaving home. But then she has a mid-morning snack in the school. It could be poha, vada, whatever. And then that's when we did the CGM and we had a conversation, we realized that what was the reason for her A1C not really being under control was the spike that she had post her mid-morning snack, and which for her reasons of not being able to carry or not wanting to carry the glucose meter or not being able to do it in the school recess period and so on, that she had never really monitored the sugars around that time. The CGM profile clearly showed. So this is her initial peak after the morning light breakfast. She takes her insulin here, but she's not able to do much to the post mid-morning snack, which is what is shooting the sugars up towards 240, 50 and could be responsible for the high HbA1c. Well, this is the use of Freestyle Libre. I'll probably stop here because what I want to show in this case is that when you start downloading this data, as I said earlier, start looking at the number of daily scans. Now, such an individual, the scan number is very poor, 4, and you can see a break here in the AGP graph. Now, let me end here and open it up with a question from myself to the rest of the team. And I'm sure the experts here could also explain that why are we seeing this kind of a break in the AGP graph for an individual who's still doing 4 scans per day, but you're seeing this break in the values, and you can see the daily readings as well, that there are breaks here. So with that, let me end today's conversation and say, thank you for having me here. I can go on and on with the cases, but let me leave some for the in-person discussion that we'll probably have at IDEC. And I'm happy to take questions and suggestions from all of you, handing it to Sanjay, Neeta, Archana, Anjali and team. Thank you so much.
Thank you so much, Manoj. That was a absolutely superb presentation, very much as expected. And we're so happy, so many people listening in. Look at the number of questions we have, almost 20.
Do we? Okay.
So I'm going to ask them one by one. But before that, for people who tuned in late, the rest of our team is all here. Of course, our leader is here, Dr. Sanjay Agarwal, myself, Dr. Neeta Deshpande, Dr. Archana Sarda, Dr. Anjali Bhatt, Dr. Nitin Kapoor, and I think Shilpa Joshi had joined in, but she's missing currently. So shall we start with the question and answer session? Some of them are repetitions, which I will not take up, but there are a lot of questions that have come up. This question has come 3-4 times. Do we still have to test blood sugar when I'm using CGM?
So as I said, yes, 2 reasons. One, some of the CGM devices still require calibration. The Abbott series does not, but some of the other CGMs like Medtronic still does require calibration, which means that you need to do your finger prick SMBG and actually enter that value when you're downloading the data. So that's the requirement. The second aspect, as I said, that it does have huge variability and a bit of inaccuracy in the hypoglycemic range. So when you have an individual who's using real-time CGM and sees on the scanner a value of say 55 and the patient is feeling absolutely comfortable, it's ideal that you do a SMBG reading at that time to verify. Let's understand that this technology has advantages. It's giving us the trends and the movement which an SMBG cannot, but it also has certain limitations of not being the most accurate in the low range, especially on day 1 and day 14 of the use of the Abbott Libre series. And then again, you will have some individuals, for reasons that we still don't understand what is the factor causing that variability, where there's going to be a huge mismatch between their interstitial fluid glucose and their actual plasma glucose. So you will have every now and then a patient who's saying, I'm using it, but my CGM is showing only 90, 100, but when I'm checking on my glucose meter, it's always showing me 140, 150. My HbA1c is still at 8.3. How do I make sense of this CGM? So you will have one odd patient who will have those. Do we have an answer for them yet? No. As long as we're using the right batch of sensors which are stored correctly, there is no aspect of quality control there. We would like to believe that technology is still amongst the best that we have, though there is still scope for improvement. And as we move towards, at least in the Abbott series, we move from the generation 1 sensors towards 2 or 3, and I honestly hope that we don't get 2 in between and we directly get the 3. You will see improvements in terms of reduction of MARD, which is an indicator of the accuracy which the FDA and other regulators require, and in terms of lesser interferences and direct transfer of data.
Thank you for that. There is one question, I think, though you have shown us the figures, Venkatesh is asking, do you use the same insertion site for insulin pump and CGM sensors?
Right, so great question, Venkatesh. Now, typically when somebody is on the pump, well, you're going to ask them to use largely the insertion sites are on the abdomen. So you may have a patient who's wearing the pump with the insertion site on the right side of the belly button, and you may have a CGM inserted on the other side, left. But is that site exclusive for the pump or the sensor? No. That same site in rotation will be used for the next pump or the next CGM insertion site. It's just that you will avoid any of the sites used either for the sensor or for the pump to be used immediately after their previous usage. So you will try and give a break to that. You will move somewhere on the side. But as I said, there is no site that you can mark and say that my right side only I'll use for the pump and left side only for the sensors. You can cross change. That entire site on a continuous basis will eventually be used for some insertion or the other. And you have type 1 showing sometimes, a little bit of pigmentation or scarring from that. And of course, this sometimes leads to issue of them getting fed up, which are issues that we deal with in our patients with type 1. We just have to counsel them and say, look at the advantage, or if somebody really wants to take a break from using that because this thing, allow them that break, because their quality of life, their happiness is also an important factor which you need to keep discussing with them.
Right. There is this little point that you have touched upon very briefly, Manoj. Abhishek wants to know, are personal CGM machines equipped to share data directly with physician?
Not really. So you can't directly, it is through the cloud software. As I said, if somebody wants to, yes. If my patient using real-time CGM wants to share the data, they can download that, and they can share it with us through WhatsApp, through email. So that kind of sharing can happen. In places where the rest of the world, where the software is officially available, you can have it connected through the cloud with permissions already shared with the doctor and the clinic, which will happen in eventuality here. A lot of clinics in Europe, especially who treat type 1 and pediatric diabetes, have the connected system where it's the entire environment and which is connected. So if you have a child using it, The parents can see the data continuously. The healthcare provider can have that data in their clinics and hospitals, and it can be all shared data which can be looked at.
Okay. Again, Abhishek asks, how, in your opinion, how comfortable are senior patients to use these CGMs?
Well, so it actually depends, and which is where your role as a physician, Abhishek, becomes important. Technology is meant to help our patients and not bother them. So when you are offering technology, you need to understand how involved the person is, how comfortable the person is. It cannot be just on the basis of their affordability. You have an individual who's otherwise comfortable with the use of gadgets. You'll have an elderly senior person who may be checking 4 times a day SMBG, getting you beautiful reports and being very systematic. And when either you discuss or they hear about this technology from a friend or a relative, they will come to you and say that I would like to use this, offer it to them. You have a person who doesn't do much in terms of using devices, is extremely wary of having things on their body, but their son or daughter in the US has called them or has visited them after 2 years and come to your clinic and said, I have heard about this CGM, doctor. I would like my parent to use this. And then the parent is extremely uncomfortable. Well, then just because the child is offering and wants to offer the best, but if the person is uncomfortable, you need to counsel the patient, and only when they understand this and they're ready for it, offer it to them. Also, I would say for real time, the person has to be more involved. Keeping a real time there and scanning just 2 or 3 times, or a maid or a servant or a family person scanning, is not going to help. The real strength of real-time CGM is multiple scanning and taking action. So I have patients who are using it, elderly, continuously using it because somebody is attaching it to them. There are 3 or 4 scans. There are missing data, like I showed in the last this thing. You have to keep talking to them that you really need to optimize this use and use it better than what they are. So if they are comfortable, great. If they are not, this thing. For them, maybe wanting to just see the trend, a professional CGM at one point to see the trend may be a better choice than the real-time one.
Right. So there is one more question, though you alluded to it briefly. Akanksha asks, please tell us what is the warming up period in freestyle Libre sensor? There are many questions on this online.
Sure. So I think that was already answered in my presentation. It's 1 hour. So that was one of the least, when we spoke about the pros and cons of the freestyle Libre, I did allude to this point that once you attach the real-time sensor, the warm-up time is 1 hour, which means the patient can start scanning and seeing the data after that 1 hour period. And which is why it's become a popular choice even in the hospitals today, including perioperative major surgeries. A lot of hospitals here in Mumbai, and I'm sure Pune and other places, are using that because your patient is in, this patient is going to be here either for an elective cardiac surgery or something. You can start using it again with a word of caution that there may be interferences, and it's more to see the trends, and probably in an ICU or hospital setting, every once in a while doing an SMBG to just verify that you're not too away from the actual sugar value.
Right. So there's this one question from Mahesh, who asks, why are readings of freestyle Libre, etc., not approved as official readings of blood sugars in many countries?
Well, your question actually has the answer in that, Mahesh, because these are not blood sugar readings. And I started my presentation with that explanation that these are interstitial glucose values which run parallel to blood glucose. They are not blood glucose readings. The essence of CGM is to start looking at the trends and values and the movement of the sugar profile. It probably will take time for them to be accepted. I don't know the exact legality, honestly, of whether they get accepted, but because of the possible disparity, especially in the extremely high and extremely low zones, they may not be considered as legally as blood sugar values. But this would change. What changes this is the acceptance of FDA for TIR as a metric to be approved for regulatory aspects. Till last year, they had rejected it. They said they want more evidence for clinical trials to use time in range as a hard endpoint of outcomes. For them, HbA1c was still the important metric, but there is ongoing conversation. They are looking at more evidence. This may change in ahead. If that changes ahead, the time in range based on CGM, then does the interstitial fluid glucose get more representative of true glucose and has more legality? Maybe.
That's really interesting. We need to wait and watch, I suppose.
True.
Yeah. So an important practical point, Nikita asks, can these systems be used by children?
Sorry, can these
systems be used by children?
Of course, yes. So most of them are approved in pediatric use and they can be used in children. There is no difference as long as the child is not going to pull off the sensor, they can use it. Today, children are also using the automated hybrid closed loop systems, which is an automatic integration between the sensor and the pump. There are two types. Essentially, the same company may provide, like Medtronic does, or then you have the movement of DIY, that do it yourself, where the patients may buy one company's pump, other CGM, and then through the means of different algorithms which have been developed by patients and the community at large, helps the integration with automated algorithms. So that's the DIY insulin pump systems.
Right. So another practical question, Sheetal asks, what precaution to be taken while using these sensors for someone with sensitive skin?
Well, great question, Sheetal, and we had huge discussions on this topic at the IDEC conference at Delhi a couple of weeks back. People sharing their experiences. Well, actually, there are some different aspects of, can I say, anti-allergic creams and substances which people have used to minimize the rash, etc., from the adhesive. But it's actually very, very individualized. If somebody who starts having an adhesive rash, which could be caused by both the Medtronic CGM that you're using here or the Libre, you may struggle. So we don't have a clear solution for that. The simpler, better practice I said earlier is the area should be clean. Let it not be put on a place which has some body lotion or creams, because that will interfere. That may increase the chance of rashes. Somebody is very hairy, they might want to ask them to shave that area before putting on the sensor on the arm and so on. But somebody who has a genuine rash to the adhesive, well, we have to wait for the non-invasive glucose sensors which are developing for them to improve, to be offered to such patients with sensitive skin and rashes.
Manoj, another interesting question. Bhavna asks, are there any issues with data privacy and security while using any of these sensors?
Well, it actually opens up a complete Pandora's box when you talk about this. And which is where, that data is actually an agreement between, an unsigned agreement, I would say very often, at least in India, between the treating doctor and the patient. When they are sharing the data with you, so as I said, this data for the real-time CGM use is something which the patient has. And they share it with the doctor, so which means they're giving you consent to go through that data. Now, can that data be used somewhere for presentations and other things? And which is where we always say that when you're using any such data, let it be discreet without the name of the patient being seen to ensure data privacy and the patient's privacy. On the other hand, when you are downloading the data in a professional system in your clinic, it is that, again, an unwritten consent between the patient that they've come to the clinic, they've put the data, and you've downloaded the data and storing it, which is from the patient's health point of view. Can you share it with somebody else? Well, ideally not. But I honestly, at this point, am not an expert into the legalities of data privacy and sharing. And hopefully, we don't have these kind of issues coming up too much in India, but we never know.
Right. So there's another interesting question, which I will interpret in a different way. Mr. or Dr. Malhotra asks, CGM may not be right for every person with diabetes. Please comment on this if you think so too. So I think what he means is that who are those people who don't need a CGM?
So, well, Dr. Malhotra, let me put it this way, that would monitoring be harmful for any individual? So if you talk about today treating pre-diabetes, diabetes with many years, one of the cornerstones for managing diabetes is monitoring of glycemia. Now, any means which is going to allow us to monitor that individual's glucose, glycemic trends, interstitial fluid glucose in a better manner, an almost continuous manner, or pick up the highs and lows, I don't think it can be wrong. What we need to, as physicians today, decide is where is it absolutely needed, because this is a self-pay country. Our patients pay for their own care. Where is the actual usage? So let me start by saying that should you as a doctor deny it to any patient who comes and asks you that, doctor, I have heard about CGM, shall I do it or not? I think if somebody is asking you whether I should monitor my sugars, I don't think any of us would be pretty much right in telling them no. Whether it's an individual with newly detected diabetes, pre-diabetes, who wants to check their sugars and see what different food or lifestyle habits are altering them, it's only a learning tool for that individual. If somebody with complications wants to again see if they're dripping low, what is happening, it can't be wrong. It's just that it's an individual choice. Should it be for everybody? Should you compel? Is it that every patient of ours on an OHA, say on a DPP-4 metformin, should be told to do CGM? Well, probably not. But if somebody wants to see it, it's their choice. They should monitor. Today, even the ACE algorithm, right up there, if you see their algorithms, besides lifestyle modification, talks about lifestyle modification and monitoring, into brackets CGM preferred. So CGM is a preferred tool of monitoring for every individual with type 2 diabetes. In India, it comes down to affordability and the frequency of such usage, which can be always debated and discussed. But I don't think if somebody wants to do it, they should be denied. At the same time, should everybody be asked to do it? We have to have that sensibilities of which patient can afford and how comfortable can he or she be when we are offering them this extra tool of glycemic monitoring.
Right. I know you must be tired, Manoj, but I'm just tempted. We have 5 more minutes, so I want to cram in as many questions. You can answer in short if you like. So Dr. Sadanand asks your comments on contribution of glycemic variability to the development of diabetic complications.
So great question again, Dr. Sadanand. And we do have a lot of theoretical evidence over the last few years linking glycemic variability through probably pathways of free oxygen radical damage, in terms of linking that variability to long-term complications. And it's not only long-term complications, it's also the hypoglycemia. So it's not necessarily the hyperglycemia, it's also the hypoglycemia, which I mentioned earlier, which often gets missed in your minimal monitoring. I mean, sometimes today we sit back and it's a thought which frightens me, that how in the past, on the basis of one single fasting with or without a postprandial sugar, have we managed a patient's diabetes and altered the dosages? How in the past, without an HbA1c or an SMBG to assist us, we have managed their treatment and made major therapeutic changes. And hence today, without CGM, without the ability to see the larger picture, sometimes the thought is frightening that, how we did this. But today we have the means to be able to see the larger picture. And that's why CGM is the way ahead for probably every patient with diabetes, at least all those who can afford it. We differentiate between looking at the trends occasionally. So if you see one of the last papers that our group, and I don't say our group, it was a lot of people who came in for that and came out with the recommendations of the TIR in Indian patients, we did put in a certain frequency. There is no strong evidence for us to have that recommendation, honestly, but we did come out with one of the proposed frequency of testing. When you're looking at professional CGM, those who are on insulin probably looking at doing twice a year. For type 1 patients, ideally more frequent, ideally should be on real-time CGM as far as possible. So there are recommendations which are emerging, but glycemic variability, I think, has more and more clear linkage with complications.
Yeah. Two last questions. One you can answer in a straight one line. Dr. V.V. Ramakumar asks, is it okay to use in ICU or in hospital management?
So I did say, yes, it's being used. Just use it with a little caution, and sometimes you need to keep validating with the SMBG, especially when you're seeing hypoglycemia. The interference part has been taken care of, and I think it's a great tool to use it in the hospitals.
So the very last question, I promise. Dr. Reshma Kangude has asked, you have answered this qualitatively, but she wants a quantitative answer to this. And the answer is, the question is, what could be like normal, considered normal, the difference between interstitial space glucose and plasma blood glucose level, or maybe capillary blood glucose level?
No, I didn't understand the question. What is
how much range can be considered normal?
So it's
Difference.
not.
Yeah.
No. So I think we're looking at interstitial fluid glucose at the same number as your plasma glucose. So it's not that the number changes. If you're talking about 70 to 180, that is not 60 to 150. It's just that you're looking at the same numbers, but just that understand that there could be a lag period. This lag period is higher soon after a meal when you would expect the spike to happen. And it's much lesser in a fasting period when the person is fasting for 2 or 3 hours or longer. So there is a lag, which means your interstitial fluid glucose is going to follow plasma glucose. So sometimes when you may see a patient's plasma glucose, it may be 140, let's say 1.5 hours after they've eaten food, and you check the interstitial fluid glucose, it could be still 100 or 110, and 15 minutes later you will see a 130 on the CGM. So that's what a lag means. The number doesn't change.
Okay. Thank you very much, Manoj. It was indeed a very, very enriching experience listening to this. So before we sign off, I would want one comment from Nitin, and then I want the summing up from Archana and vote of thanks by Anjali.
Thank you, Dr. Manoj. I believe it was absolutely crystal clear. A very, very nice lecture, very clinical, practical. I actually had one small question, and this is a patient that I saw yesterday. I've seen very different practices while I was in Australia and while in India. And this particular patient was put on a CGM Libre, and the rheumatologist asked for a DEXA scan the third day. And then the patient is back. Should I remove it or should I keep it? I know, I mean, CT scans, MRIs are, I mean, what the pamphlet says is no, but for DEXA scans, there are huge different recommendations. In one hospital where in Melbourne I was working there, they were okay with it. And this patient really didn't have an answer. I've used it before, but I don't know what accuracy, what happens to the accuracy of the results. What is your take or recommendation on that?
So great question, but difficult question, Nitin. But the simple answer is, from what I've known and used, DEXA scans have not been a usual problem. As you mentioned, MRI, if somebody is undergoing MRI and you're aware of it, don't put your patient onto it. If they are on a sensor, they will have to remove it. It does interfere. But DEXA scans, to the best of my knowledge, would not interfere, and it's okay for the patient to wear it undergoing a DEXA scan.
Yeah, great, thanks.
Archana.
Thank you. Thank you so much, Dr. Manoj. It was, I think it is a lot of, only the lot of passion can make you talk for an hour and then so patiently answer all the questions, and that too so practically addressing each person. I think we have learned a lot today, and I would only summarize by saying that technology for patient care is what we are talking about, and it's very important to know our basics right. So there are a lot of myths I realized from the questions, a lot of hearsay, a lot of fallacies, which may be true or maybe something we can work around with. But the best way to offer our patients the technology that exists today and be able to give them the best outcomes is to learn ourselves. And that is what has happened today in the entire workshop. We have all learned a lot of new things. And at the same time, I will voice what Neeta said, that the next 2.0 of Dr. Manoj version of CGMS will happen in IDEC. So I invite all of you to IDEC in Pune from 30th of June to 2nd of July, where we can learn firsthand, hands-on, whatever doubts we have. So my take-home message from the entire day is we still need to learn a lot. So let's have our facts right. Let's get the basics right. Let's ask all these questions and clarify and give our patients the best. Thank you. Thank you, Manoj. Over to you, Anjali.
Thank you.
So can't thank enough to Dr. Manoj sir. Always passionate about technology. Thank you, sir, for spending so much time, energy, resources in helping our audience understand how to use CGM. I'm sure we took it from very basic to the most advanced way of using the technology. Secondly, I would like to thank the audience who is here to understand such an important nitty-gritty, spend time at this hour of the night, ask questions and try to understand how to apply this knowledge in clinical practice. And if I may pat our backs, I would like to thank the whole IDEC team, including the organizing committee, as well as the people who are working at the back about arranging the conference, putting it on the website, reaching out to people. And I wouldn't be able to take everyone's name, but thank you to the team. And with that, I'll hand over to Neeta again to sum up. Thank you.
Sanjay is here. Sanjay, would you like to say something before we close finally?
Sanjay's gone to sleep. I'm gonna wake him up.
Well, anyway, nothing more to say. Thanks a ton, Manoj. Great job. Thank you very much.
Thank you, guys. Thank you. Thank you
Thank
for having me here. I enjoyed it, and see you guys soon.
Thank
And
thank-
today's
you,
talk
sir.
will be on the IDEC website very soon. Within a week, it would be available there for everyone to revisit.
Bye. Bye. Good night, everyone.
Good night. Good night. Thank you, Dr.